Thank you. Yes, so I have the enviable task of talking about hospital value-based purchasing. And I think, as I think about this topic, I think it can become quite complicated, but I'm a simple general surgeon like I think most of us in the room, so I'm going to try to keep this as simple as possible. Payments linked to quality are here to stay. This is just a couple of graphs to show you what percentage of Medicare expenditures are related to, are linked to quality in one way or another. And you can see that in 2016, 85% of all Medicare expenditures to hospitals are going to be linked to quality, and that is intended to go up to 90% by 2018. And what I'm really going to talk about is the light blue area, which is that fee-for-service that's linked to quality. I'm not going to touch on the darker blue, which is the alternative payment models that some of us are experiencing. And just to be clear, so we're all on the same page, so we're talking about just now Medicare payments, and as you know, Medicare has multiple parts. I think now they're up to Part D. But the initial parts were Part A and Part B, and Part A focuses on hospitals and Part B on physicians, and hospital payments and physician payments. And this is the hospital value-based purchasing program is focused just on Part A, just on the expenditures to hospitals. Now, this is part of Medicare's effort to link systems changes or payments to make system changes that improve quality. It's part of the Affordable Care Act, which we're all familiar with. And a few things you need to understand about it. So basically, the program is intended to give either bonuses or penalties to hospitals based on their performance, and I'll list what the metrics are for those performances. It began in 2013, and over the last 3 years, and this is intended to increase in the future, more and more of payments to hospitals are withheld at the time of the payment and then returned potentially at the end of the year based on the hospital's performance. And in 2016, it's 1.75% of all Medicare Part A expenditures. I think the important thing for us to remember is that it does not directly impact physician reimbursement. So there is not a program right now directed at Part B for physician reimbursement, although I think we're all aware that this does impact how we practice and the environment we work in, and may well down the road or indirectly impact our reimbursement. So this is just a graph to give you a sense of how those dollars at risk have increased over time. It started at 1% in 2013, and it's going up 0.25% per year. So by 2017, it'll be up to 2%, and perhaps will increase beyond that. I think the other important thing to understand is that what Medicare considers and CMS considers quality has changed over time. You saw a little bit of this in Ann's introduction, but in 2013, it was really only two areas, which were clinical processes of care and the patient experience of care. And over the ensuing time, the distribution of dollars that are based on these various metrics has changed, so that now there are four aspects, and I'm going to go over them shortly. Not only those clinical processes and the patient experience, but also outcomes of care and also hospital efficiency. So as you can see, clinical processes of care used to be 70%. Now it's down to 10% of the dollars at risk. 25% is for the patient experience, 25% for efficiency, and actually 40% for outcome. And what I'm going to do, just to help you understand what are actually go into those metrics, is I'm going to walk through each of those different areas and tell you what CMS is actually using to evaluate hospitals. So this is the clinical processes of care. We just heard a little bit about the skip measures. And what I've done here, these are the clinical processes that are being used right now for that 10%. And in red are the ones that I would say impact us as surgeons. And you can see some of the skip measures are very clearly related to us. Prophylactic antibiotics, discontinuing prophylactic antibiotics, removing catheters. I think we've all seen the impact of this in clinical care programs in our institutions. Some around perioperative cardiac care and venous thromboembolism, and then I'm not quite sure influenza immunization is directly related to surgeons, but I know it pops up on the screen every time one of my surgery patients gets admitted, so I thought I'd list that as red. Here's the patient experience of care, and again, the HCAP surveys, I think, do really touch on every aspect, or every aspect of the HCAP survey touches on surgical patients. So patients are asked how how was the communication with nurses and doctors? What was the responsiveness of our staff? How was their pain management? Obviously very important to us. How was the communication about medications? How clean and quiet was the hospital? How clear was their discharge information? And what was their overall rating of the hospital? So again, all those things touch on us as surgeons and surgical patients. And then what are the outcomes measures? So actually there's no surgical measure of mortality used right now, but there are patient safety measures. So the patient safety indicator is now, I think there are 20 aspects of that survey, and they actually include the new accidental puncture or injury that we are supposed to include in our coding and dictations, but also includes, again, VTE prophylaxis and perioperative antibiotics. And then also alluded to earlier, a number of infections that can impact our patients. Catheter-related infections, UTIs, and specifically surgical site infection rates for colectomy and hysterectomy are the two procedures they're looking at now. And then finally, there is an aspect of efficiency. So what Medicare is doing is looking at Medicare spending per beneficiary. Now, this is really interesting. This is at the hospital level. It actually goes from the 3 days before admission to 30 days after admission. And it's total expenditure in that time. It's actually expenditures in Part A and Part B on that one patient's visit. And then it's adjusted for case mix, and it's compared to the national average for that same diagnosis. So a little bit more about by the numbers. I said it's 1.75% withhold at this time of DRG payments. That's about $1.5 billion annually or in 2016 that are being withheld and are at risk for our hospitals. It turns out that more than half of the hospitals involved are getting bonuses, which means they're seeing a net increase. So you can actually get more than your 1.75%, or other hospitals, less than half, are seeing penalties and reductions in their DRG payments. I think for some of us, or many of us, we may practice in safety net hospitals. And one of the concerns in this program is that safety net hospitals will be unfairly penalized. And that is probably because the case mix adjustment is not quite up to snuff and doesn't directly or completely reflect the patient mix in those institutions. And it does actually show that safety net hospitals are being penalized more than non-safety net hospitals, and this is actually actively being researched, and the CMS is interested in trying to make this more equitable. So the landscape continues to change. I'm talking about value-based purchasing here, but there are actually two other major quality improvement programs that Medicare is undergoing. One is around readmissions. The other is about hospital-acquired conditions. And again, these may not directly affect physician payment and surgeon payment, but certainly will indirectly impact us. And not surprisingly, these are relatively new programs, and their net effect is really not known yet, but is being actively studied. So I'm just going to sum up to say, what does this really mean for us as surgeons? I think we know that, as you can see, a number of these metrics that are directed at hospital payment are actually directly related to our surgical care. So the care we deliver can impact our hospital's reimbursement, and our hospitals are going to be motivated to get us to perhaps change how we practice in order to, for them to get those dollars at risk. Value-based purchasing doesn't directly impact surgeon reimbursement through Part B, but certainly has already, I'm sure we've all seen some effect on our surgical practice. And I think as more and more surgeons are hospital employed, I think the chance that this could be passed along to the physicians and the surgeons in a hospital is highly likely. I think the other thing, in some ways, value-based purchasing may seem like a bad thing and something we'd like to avoid, but I think if you look at the bright side, this does really encourage we as practitioners and our institutions to focus on things that we are all very interested in and find very important. Obviously, our patient outcomes, our patient satisfaction, and the efficiency of care. And I think one of the benefits I think we've hopefully all have started to see are institutions focusing a little bit more on things like patient satisfaction, efficiency, particularly around the operating room, and that has a direct benefit hopefully to us. I do want to acknowledge one of my residents, Tom Tsai, who actually spent 2 years at the Department of Health and Human Services and probably knows more about this than I do and was very helpful in me putting together my talk today. So with that, I will just say thank you. There you go.